Moderators, please.
Hello, good morning, good afternoon, everyone. So, this session, we are discussing about endoscopic management of the higher biliary obstruction. So, in this field, we have still struggling. What the treatment is best? So should we do the drainage from the total river or only from the partial river? Or should we use the plastic stent or the metallic stent? Or should we press the stent above the papilla or the across the papilla? And recently, the patients lives longer, survives longer, so that we have to replace the stent. So for the first stent, should be used the plastic stent or metallic stent, or the secondary is what stent is used. So now today we are discussing about that all of the problem, and yes. So I want to introduce the first speaker. So our first speaker is Dr. Hamada, and he talked about the revised Tokyo criteria for the higher biliary obstruction. Dr. Hamada is making the devising the Tokyo criteria for the evaluation of the higher treatment of the higher biliary obstruction. So please start your presentation.
Thank you so much for your kind introduction, Dr. Fujisawa. I'm Choshi Hamada from Department of Gastroenterology and Endoscopy, the University of Tokyo, Japan. It's a great honor to be here today to talk about this topic on behalf of all the members of the Japanese Society of GI Endoscopy committee members. My topic will be the revised Tokyo criteria for higher biliary obstruction. No conflicts of interest to disclose. So I'd like to begin with what are the criteria? What are the Tokyo criteria 2014? This is a story going back to 10 years ago when we tried to propose standardized nomenclature for biliary endoscopic, the clinical outcomes of endoscopic biliary drainage. And at that time, we had unmet needs in clinical practice and clinical research caused by non-standardized nomenclature. And taking example of this meta-analysis, including 5 studies, we only included the 3 studies for the primary endpoint evaluation. And also, the terminology is confusing since I'm not sure what's the difference between stent patency and stent survivor. So we are motivated to propose a standardized reporting system for transpapillary biliary stenting, which was actually published in 2015, which was termed the Tokyo Criteria 2014 for transpapillary biliary stenting. And thereafter, however, we had emerging unmet needs since the Tokyo Criteria 2014 mainly focused on transpapillary stent placement for distal biliary obstruction. And also, the criteria didn't cover recent drainage modalities, including EUS-guided biliary drainage or balloon-assisted biliary drainage. And more importantly, the Tokyo Criteria 2014 lacks the concept of evaluating the overall clinical outcomes during a period requiring biliary drainage from the perspective of patients' experiences. So we are motivated to revise the Tokyo criteria here. And as a committee members of Japanese Society of GI Endoscopy, we established a research group of evaluation criteria for endoscopic biliary drainage as a workshop of JGES the society. And on the annual congress of JGES, we had a joint face-to-face meeting in 2021, 2021, and 2022, and 2023. And we had the opportunity from public hearings, including from JGES members during the annual meeting in 2023, and from general audience on the JGES website. We now target 7 conditions and interventions within the framework of the revised Tokyo criteria. We now target 3 conditions, including distal or hilar biliary obstruction, as well as benign biliary stricture. As the interventions to be evaluated, we evaluate US-guided biliary drainage and balloon endoscope-assisted biliary drainage, scheduled extent exchange, and biliary ablation. Then in this talk, I'd focus on this part of hilar biliary obstruction. Here I summarize major revision in the Tokyo criteria 2024. We have added cholangitis without jaundice as an indication of drainage, in addition to jaundice only. And we have expanded the target conditions and interventions as I described in the previous slide. And most importantly, we have defined this stent demand time, SDT in short, as the entire duration of endoscopic biliary drainage, which aimed at the evaluation of the overall stent-related outcome during SDT, and also overall patients' experiences during SDT. And to evaluate the clinical outcomes during SDT, we have proposed these reporting outcomes, including technical or clinical success, recurrent biliary obstruction, as well as time to recurrent biliary obstruction, and resolution of biliary stricture for cases with benign biliary stricture. And also, we have included adverse event, including RBO and non-RBO adverse event, including pancreatitis. So let's focus on the part of hilar biliary obstruction within the framework of the Tokyo criteria 2024. And I'd like to show the 2 cases with hilar cholangiocarcinoma to show how to evaluate clinical outcomes of the patient receiving endoscopic biliary drainage using the revised Tokyo criteria. So for the first case, I indicate the timeline for the upper arrow. So for the first case, this person received the endoscopic placement of multiple metal stents in partial stent in stent fashion. And the initial time to recurrent biliary obstruction was pretty much good, which was 8 months, as shown in a randomized control trial. But at this point, this person experienced the stent occlusion and resultant cholangitis, and we performed re-intervention using the multiple plastic stent for the bilateral bilacs. And we performed multiple re-intervention for this patient. It's actually re-intervention, and re. And then at this point, indicated by red arrowhead, we had to perform percutaneous drainage because of this patient had a cholangitis due to the segmental cholangitis caused by placed metal stent. And we exchanged our percutaneous drainage here, and unfortunately, this patient died at 30 months of stent placement due to cholangitis. And moving to the second case, this person received the multiple plastic stent placement for hilar cholangiocarcinoma. And given that there might be a possibility of resection for this patient after neoadjuvant chemo, we placed a plastic stent, and we performed repeated scheduled exchange for this patient. Unfortunately, this patient didn't undergo emergent admissions. And at the very end of his life, he experienced cholangitis due to stent occlusion, and we performed the nasobiliary catheter placement. And soon after, this person died due to the progressive cancer without cholangitis. And let's go back to the definition of the reporting items for STT. And the stent demanding time STT has been defined as the whole period requiring endoscopic biliary drainage. And its definitely starts at the time of stent placement. And the end time point for STT might depend on a case by case. For example, maybe the most common definition of end time point is death for most cases, and also the resolution of biliary obstruction or surgery for an underlying disease might be end time point for cases with benign biliary obstruction and resectable cases, respectively. And technical success has been defined as a successful placement of at least one stent or catheter in the intended location across a higher obstruction site. And clinical success has been defined as more than 50% of reduction or normalization of total bilirubin within 14 days of stent placement. And for cases with drainage for cholangitis, the clinical success might be defined as a resolution of cholangitis, which is stopping antibiotics or more than 50% of reduction in blood inflammatory markers, including white blood cell or C-reactive protein. And recurrent biliary obstruction can be defined as we did in the original Tokyo criteria, which is defined as a composite endpoint of occlusion or symptomatic migration of stent. And the time to recurrent biliary obstruction, time to RBO, has been defined as a time from stent placement to RBO. And we propose that the time point of RBO is the point when associated symptoms are noted. And regarding adverse event, we propose AEs can include RBO as well as non-RBO AEs, including pancreatitis, cholangitis, and so forth. And let's get back to the two cases with hypercholangiocarcinoma. I want to note that the time, stent demanding time, STT, is exactly the same for both cases, which was 30 months after stent placement. And the total number of procedures was pretty much same, 8 for metal, 7 for plastic stent placement. However, the total number of adverse events, including RBO and non-RBO AEs, was higher for metal stent because of the repeated episode of cholangitis. And cause of death was cholangitis for metal stent case and cancer for plastic stent. And the case with metal stent placement eventually received the percutaneous drainage at death. This is just an example, but I'd personally like to receive the second stenting strategy. What do you think? In conclusion, the revised Tokyo criteria 2024 we have just proposed would help design and report clinical studies on various endoscopic biliary drainage procedures in a standard manner. And we hope the criteria would enhance the comparability of study results and better interpretation. I'd like to finish my talk appreciating all the members of JGES committee members, including the project leader, Hiro Isayama, Juntendu University. Thank you so much.
Thank you very much for your great presentation. So, anyone has a comment or other questions? So, I have one question. So So I'm also interested in the evaluation of the patient's quality of life. So you show the two cases of the metallic stent and the plastic stent, and the one case has a PTBD in the last period of the patient the life. So what is the most important factors should we evaluate the patient quality of life? Using a PTBD or the number of the replacement of the stent, or what's the most important factors?
Unfortunately, I don't have an answer now. Maybe let's discuss it in a future research. Maybe the quality of life of patients receiving endoscopic biliary drainage might be the most important. But the second would be the cost effectiveness, I think. And given that we have proposed this criteria, the next step would be what reporting item would be most strongly correlated with quality of life. It might be a single outcome variable. As you mentioned, is the presence of plaquetary drainage or a combination. Something like we have to have a weighting on the events, maybe. Maybe the one episode of cholangitis is maybe is not as much as receiving the plaquetary drainage, I think. So maybe, yes, that kind of validation study I want to do from now on. Thank you so much.
Dr. Isayama.
So one comment from the Dr. Isayama. So I think QOL is related with received procedure time, but I also received unplanned intervention or planned intervention. It is different, I think. So the Dr. Hamada a very good summarize the typical cases of the hierarchical carcinoma. So similar procedure times, but numbers, but so unplanned means RBO. Maybe it is strongly correlated with the QOL. So also PTBD. So also we want to avoid PTBD for such kind of a patient. Then we employ these items. So it is very important for especially in hierarchical carcinoma. My comment.
Thank you very much.
Thank you so much.
Any comment? Okay. Thank you very much for the presentation.
Thank you so much.
So I want to introduce the second speaker's presentation. So, our second presenter is Professor Jong-Hon Moon. He is one of the most famous doctors in the endoscopic field. So he is making the metallic stent, so many of the metallic stents. So maybe we can heard the data of his own metallic stent. Please present your data.
Thank you very much, Mr. Chairpersons, Dr. Fujisawa, and Dr. Kogure, my good friend. And it's my great honor to be here. Still, endoscopic stenting for hilar malignant biliary stricture is a very challenging and complex procedure comparing with distal CVD stricture. Now the goal should be the drainage of the viable liver volume over 50% without cholangitis, here already mentioned. And definitely metal stent has many, much better than plastic stent comparing many ways, including patient survival time from this study result. Recent ASG guideline also suggests metal stent for unresectable malignant hilar obstruction. We did a study for comparing bilateral with the unilateral placement of the metal stent for inoperable high-grade hilar malignant biliary stricture we compared this like this, and we accepted a stenting stent and or side by side. With the study result, bilateral metastent shows a high clinical success rate and fewer interventional rate and a very low adverse event, and also significant longer stent patency. Again, ACG guideline for malignant hilar obstruction, they suggest the bilateral stent. But they didn't mention about stent height, but they draw like a metal stent like this. And these are indications for bilateral metastenting. There are two techniques for bilateral metastenting. Maybe a side-by-side deployment have some problems. One technical development is side-by-side simultaneous bilateral stent deployment using metastent in 6-branch delivery system. With technical improvement now, we are having even weaving stent, not laser cutting stent, weaving metastent in 6-branch delivery system like this. And with the kind of conventional weaving stent, we can introduce two metal stents simultaneously over guide wire and can make a side-by-side deployment. And stent deployment is more ideal in physiology because of two large bore stent can be expanded within a single stent caliber lumen using that kind of specialized metal stent. And our group reported the high technical and clinical success rate using a cross-wire metal stent for the large scale, the long-term study, and very acceptable early and late adverse events. And recently we compared which method is better for advanced hilar malignant stricture. And we compared stent in stent and side-by-side deployment. Primary outcome was the rate of adverse event. From the result, there was no differences about the rate of the adverse event and also success rate, re-interventional rate, also standard patency. So we need more data, which one is better. And with the increasing success rate using new accessories and stents, we can perform triple branched metal stenting with stent in stent deployment. Let me show this case after stenting to left side. And second stenting is going up the right anterior sectoral duct. And after deployment, searching to right the posterior sectoral duct with guide wire. And third stent is inserting through the central mesh of the first stent. And now we can make a triple branched metal stent. We also reported the relatively high clinical and technical success rate using triple branched metal stent. And also, there is another triple branched metal stent using hybrid deployment, like we can make a combination of side-by-side and stent-to-stent deployment. Some Japanese groups, including Dr. Nakai, reported about this method. Recently, we have even LCD stent in 6-branch delivery system. So let me have this case, and 2 6-branch LCD delivery system is introducing over guide wire. And then at first we can make a stent-to-stent deployment simultaneously. And using guide wire after searching right posterior sectoral duct, now first one is side by side, and now stent-to-stent deployment through the central mesh of the first stent. And we can make a shorter procedure time using that kind of new device. And this is a final picture. And Dr. Matsumoto compared the bilateral with the triple branched metal stenting, but there was no differences of stent patency. And these are current issues for bilateral metal stenting, especially with the improvement of palliative treatment and patient survival. Now, stent revision is a big issue after stent occlusion. Let me show this very high-grade hilar stricture. At first, we did the bilateral stent-to-stent deployment with the cross-wire metal stent. 6 months later, stent was occluded, and a third cross-wire stent is introducing through the lumen of the first right duct, and then using guide wire, searching for the left intrahepatic duct, and then fourth cross-wire metal stent is introducing over the guide wire through the two right side cross-wire metal stent. So finally, we can make a second revision for stent deployment. And final pictures like this. And we also reported about the revisional outcomes for occluded cross-wire metal stent with a high technical success rate. And another issue is the location of distal tip of stent. And transpapillary stenting can make easy access of the revision, but the suprapapillary stent tip location can prevent direct duodenobillary reflux to liver. So personally, I prefer the intraductal stenting end. And Dr. Kano compared, and he will talk about it later. And another problem is acute cholecystitis by cyst obstruction. So now it can be a good indication, not only a good indication, perfect indication for US-guided internal drainage using LAMS. We are using Spacious on heart delivery system. Let me show this case. For this patient, he did a bilateral stent metal stent placement, but very easily to going to acute cholecystitis with the extension of the cancer. For this patient, after puncturing the gallbladder, and then heart Spacious is introducing over the guide wire and deployed in proximal flange inside the gallbladder, and then walking channel deployed, and finally, proximal end is deployed on duodenum. And now we can use US-guided biliary drainage for stent revision with their HGS and integrated drainage. We developed the Spacious MG for US HGS, having 20 millimeter of proximal flange here to make a complete folding back to prevention of migration and access route for the bile duct. Let me show one case. This case did the stent deployed, but the patient did multiple re-interventions after stent placement. But again, recurrent obstructive jaundice was occurred. So now we did the US-guided HGS using Spacious MG after puncturing on B3 and guide wire insertion. And then distal flange deployed. Finally, proximal flange deployed inside the stomach. But these are limitations, current endoscope revision for occluded bilateral metal stenting. So now some groups has been used the bilateral fully covered metal stent, usually from Japanese group. And Dr. Isayama group also reported about the bilateral 6 millimeter slim fully covered metal stent for hilar obstruction with a good technical and clinical success rate and acceptable adverse event. And also Dr. Inoue reported about bilateral intraductal stenting using novel 6 millimeter threaded fully covered metal stent with a good result like this. And one Korean group compared the 6 millimeter fully covered metal stent used with a conventional 7 French plastic stent. And they showed the fully covered metal stent can be a preferable method comparing with bilateral plastic stenting. So we are using non-flared fully covered metal stent as the intraductal fashion, having 8 millimeter diameter and long lesser. Let me show just the case and hilar block here. And after stenting by side deployment using short length of intraductally located fully covered metal stent. And then you just show only lessors on duodenal side. Like this final photo. 6 months later, after stenting, cholangitis occurred, RBO, and the stent is removed, just pulling back the metal tip of long lesser, and the two stent is completely removed smoothly. And then again, we can put there another second revision for side-by-side deployment using same short length of intraductal fully covered metal stent for the revision. And final photos like this. But still, we have many limitations of the fully covered metal stent, especially high-grade hilar malignant obstruction. So in conclusions, with introductions of new accessories and stents, endoscopists like a biliary endoscopy can have expanding therapeutic roles for the management of malignant hilar stricture. And endoscopic metal stenting for inoperable high-grade malignant hilar strictures can be a primary effective and safe method. Bilateral metal stenting can be better than unilateral metal stent, but for the deployment technique, we need more data, and also we waiting further data about the result of fully covered metal stent. Thank you for your very kind attention.
Thank you very much, Dr. Moon. So is there any question or comment from the audience? Dr. Isayama, please.
I'm Isayama. So, it's John, very good talk. So,
Thank you.
as always.
One,
So, introduce many types of the stenting. So, mainly uncovered metal. The last is fully covered metal stent. So, I want to know the actual your clinical procedure. So now you select uncovered or fully covered metal stent for the hilar obstruction or case by case. Please say your give your opinion.
from the first stenting, like you, I'm using bilateral plastic stenting or 3 plastic stenting. But after patient met with RBO, at that time I need some discussion with our team for going to the metal stent or second round of plastic stent, especially a younger patient and expected longer survival. It means very effective for chemotherapy responses. And then we can make the decision which one is better by case, like uncovered metal stent, usually older stent, a little bit shorter life expectancy, and we thinking about the uncovered metal stent, bilateral stenting. But the other side, we are thinking about the fully covered metal stent. But honestly, I'm not fully satisfied about current fully covered metal stent, even the kind of short length of the intraductal fully covered metal stent also. Maybe we need more study about designing of the kind of fully covered metal stent, especially for relieving a hilar malignant block, especially bismuth type 3 and 4 ones is still the problem is blocking of the side branches. So some of my patients suffered in liver abscess also. So B2 is perfect, no problem. So, and a little shorter B3 is 3B is okay, but the 3A is also can make another problem because we need a deep insertion of the fully coated metal stent. It can make us high possibility of the blocking of side branches.
Okay.
But it's very different by case.
Okay. But you mentioned the indication of the uncovered metal stent is decreasing.
Decreasing. It's a same phenomenon in Japan and Korea.
Okay.
I think so.
Thank you.
Any other comment? So please, Takahara.
My name is Dr. Takahara from Tokyo University. I want to ask you, what is the best surrogate marker, surrogate out point to evaluate the efficacy of the hilar biliary drainage?
Number 1 is relieving cholangitis. And number 2 is normalizing liver function.
how about QOL or TRBO to evaluate? What is the best definition of the successful drainage for the hilar obstruction?
It means like normalizing liver function without cholangitis can be the most important, because even after perfect stenting, patients still suffered from the cholangitis. So not depend on triple or bilateral. Some patients still suffer cholangitis. It's not. It means even we did the very advanced endoscope procedure, it's not a perfect procedure.
Thank you.
Dr. Moon, I have one question.
Yes,
So
please.
if you are planning to do the radiation therapy or the RFA for the hilar migrant structure, so you can use the metal stent or should be the plastic stent?
Maybe Dr. Joe will talk
Yes.
about that. So for my institute, RFA is a routine clinical practice. We are trying to almost all patients with hilar cholangiocarcinoma for RFA without any absolute contraindications.
Yeah.
So, and radiation therapy is very rare in my institute. And for RFA, so we should consider about continuous plastic stenting even after RFA or change it to metal stenting, also by case by case.
Okay, thank you very much. Okay, thank you very much
Thank
for
you.
your presentation.
Okay, let's move next speaker. Next speaker is Jae-hee Ko from Yonsei University, Korea. Jae-hee is my friend because of we have a Korean-Japan joint meeting many times. So his topics is biliary RFA for hilar biliary obstruction. Please start.
Thank you for kind introduction, friends Kogure and Toshio. And I'd like to talk about the biliary RFA for hilar biliary obstruction. No COI. As you know, hilar cholangiocarcinoma is a rare malignancy, but the rising incidence in worldwide, and diagnosis and management are very difficult and challenging. And only cure is achievable by surgical resection, depending on the resectability and remnant liver function. In order to overcome the poor prognosis, there are many efforts being made in terms of anti-cancer treatment and palliative care. However, we need to individualize multidisciplinary approaches should be needed. There are many technical efforts and new attempts were tried. In terms of palliative care, new stent design, development, and stent delivery method were studied. And local therapy is actively studied by the many groups, RFA, microwave ablation, and cryoablation, and so on. As you know, the RFA is a promising treatment modality, so that if the early stage of cancer, RFA may be able to cure, and in the later stage of cancer, it may be able to reduce the tumor burden. RFA involves the local application of RF thermal energy, and that is achieved by high temperature, by high frequency alternating current that may result in coagulation necrosis. There are two types of the RFA in the pancreatobiliary cancer. US-guided RFA was performed like this, just like the routine US-guided FNA procedure. However, ESP-guided RFA is along the guide wire, RFA catheter was inserted as done by the just routine ESP procedure. In terms of ESP-guided RFA, there are two kinds of the RFA system. One thing is Habib. Habib is a bipolar RFA with a fixed 25 mm ablation length, so that it made by the LVAD generator. However, on the other hand, LRFA catheter is RFA is a temperature controlled bipolar RFA. That means when tip temperature reaches the presetting temperature, it will be automatically turns off per minimizing operating injury. It has a per kind of different length, so we can adjust the RFA more precisely according to target lesion. However, it has shortcomings. It needs the special Vivo combo RF generator. This illustration shows that malignant distal biliary obstruction RFA, two visible bipolar electrodes, RF energy circuit that deliver alternate current to produce ionic agitation and thermal ablation to the mass. Fortunately, our group has using the LRFA system, we did a preclinical animal study and in human study. In preclinical animal study, you can see the RFA-related post-coagulation necrosis in microscopic examination. And in terms of long-term results of RFA, you can see the post-RFA stricture on cholangiogram. In human cholangiocarcinoma, RFA may result in the coagulation necrosis, and median of maximal effective RFA depth was estimated to be 4 millimeter depth and range from 1 to 6 millimeter. And effective ablation length that was defined the histologic ablation length by fluoroscopic ablation length is about 70%. The 70% of RFA probable length was completely coagulated after RFA. There are many accumulating data to show that feasibility and safety of EB-RFA in distal mammography obstruction. This summarized table showed, however, controversial therapeutic outcomes with even conflicting. You can see the survival benefit of EB-RFA in ladder error, but you can also see if they are not. So there are many pros and cons in terms of the RFA effects. In the positive aspect of EB-RFA, 3 studies showed strong evidence. This meta-analysis of the Habib-RFA, they showed that prolonged stent patency and survival benefit. In 2 Chinese groups, including extrahepatic cholangiocarcinoma, they showed that longer stent patency and overall survival benefit. However, phase 2 Korean multicenter and Korean prospective RCT showed that there is no difference of stent patency in overall survival between 2 groups. And recent German multicenter study showed that no difference in stent patency and overall survival. For these controversial effects, we did a multi-center retrospective study. We enrolled 170 patients, and PSM was matched as a 1-to-1 ratio, and each group had 44 patients respectively. However, recurrent biliary obstruction did not differ between 2 groups, and overall survival did not differ between 2 groups. And Cox regression analysis showed that there is no significant risk factor associated with prolonged survival. So there are many pros and cons and controversial reports. We think again, the factor related to the conflicting results. Previous RFA study have some issue to reconsider the interpretation. First is the study design, a small sample size design and difference of highlight involvement and various cancer included. And in terms of EB-RFA method, there is an inconsistency of RFA protocol and various type of biliary stent, plastic or metal stent were used, and route of RFA via ERCP or PTC is different. So there are unsolved issues as indication and cost effectiveness, RFA contact problem, and unclear mechanism of survival benefit. So I think that if we draw conclusion from previous reports, the best therapeutic outcome in the RFA can be expected to be the intraductal lesion, such as cholangiocarcinoma, and locally advanced type, and multiple and repeated EB-RFA with regular stent exchange is related to prolonged survival outcome. Let's move to main topic, EB-RFA for perihilar lesions. As you know, the perihilar lesion has a very complex bilobascular system. So I'd like to continue my talk with the question and answers. All the studies show that severe complication, liver infection or hemophilia, but I think that there is related to the higher RFA, so that persecution is easy EBRFA safely applied to perihilar lesions with conventional RFA energy setting for malignant distal biliary obstruction. For the difference RFA energy RFA catheter according to target lesion, we did a preclinical animal study on the various RFA catheter and energy. First picture showed that the 11 millimeter RFA catheter, 7 watt, 2 minutes, usually recommended RFA energy to malignant distal biliary obstruction. If the mini pigs, the perihilar RFA was performed, you can see the perforation. However, low energy setting, 7 watt, 1 minute, after the higher RFA in the mini pig, there is no perforation and complication. So among 6 mini pigs, 4 mini pigs had a perforation and with abscess in the conventional RFA energy setting. So, however, higher RFA with low energy setting, there is no perforation or abscess. So, considering the risk of fatal complications such as hemophilia and so on, it is necessary to perform EBRFA with low energy using shortest RFA catheter. As a 7 watt and 11 millimeter RFA catheter is needed. This picture shows that the amplitude of the bladder cancer RFA real-time image. However, we could not see the intraductal lesion. So I'd like to raise a second question. Could EBRFA really ablate the perihilar lesions? Actually, spyglass is more useful viewing the intraductal lesion. This patient has a PSC and the common hepatic duct, hilar duct cancer. Before the RFA, you can see the irregular vessel and the irregular mucosa. However, after EBRFA, 22 millimeter RFA catheter 10 watt 2 minutes, after the RFA, whitish bond mucosal tissue is noted. So that actually EBRFA can ablate the mucosal lesions. Although the ablation effect of EBRFA cannot be predicted by cholangiography only, the local ablation effects of EBRFA can be confirmed through the spyglass. The other question is RFA really an effective treatment for hilar cholangiocarcinoma? This multicenter retrospective study including unresectable perihilar cancer, we used 7 watt and short RFA catheter and 1 minute to 2 minutes, depends on the patient condition. There are only 3 patients had adverse events, cholangitis, cholestasis. This study showed the safety and feasibility of the in EBRFA in the perihilar lesions. After retrospective study, we did a prospective multicenter study to verify safety and efficacy of RFA in malignant hilar biliary obstruction. First, RFA and bilateral plastic stent was performed. After that, second bilateral SEMS was introduced. RFA group and non-RFA group has 15 patients respectively. There is no difference in adverse event and technical success rate. Interestingly, stent patency and overall survival did not differ between 2 groups. However, where the structural length is more than 11 millimeter, RFA is associated with longer stent patency. And although first plastic stent indwelling duration after higher RFA did not differ between 2 groups, unscheduled plastic stent exchange due to incidental stent occlusion is more common in non-RFA group. So we concluded that higher EBRFA is safe and effective, especially longer structure, and it could prevent the premature plastic stent occlusion. Actually, RFA has an obvious limitation. This is a palliation therapy for the target lesion. Therefore, we did the next therapy step. We did development of anti-cancer treatments such as combination chemotherapy, immunotherapy, and so on. There is many efforts to achieve the survival gain in this patient. I'll show you this video clip. Classic tumor bilious type 4 and he underwent laparostomy due to liver metastasis. He has a long period of GPA chemo, RT, and optimal immunotherapy. First, EBRFA was done and the plastic stent insertion. Second, EBRFA is performed and the plastic stent exchange. We aim to solve the EBRFA with uncovered stem insertion because life expectancy is expected to be less than 6 months due to disease progression. First, the cholangiogram findings showed that multiple structure in the perihilar regions. After guide wire negotiation, we tried to 3-sectorial guide wire insertion. After that, using the 11 millimeter LRFA catheter, 7 watt, 8 degrees Celsius target temperature and 1 minute, right superior branch is 5 times the RFA was performed, and right inferior is 2 times, and left IHA did 2 times was performed. Move down the RFA catheter to additional RFA. Just like this, 3-sectorial RFA was performed, and the endoscope views show that the tumor debris. After that, we usually perform the uncovered side-by stent 3-sectorial biliary drainage. Simultaneously, 6 French size 8 millimeter uncovered stent was introduced right and left side. After deployment of the right inferior branch across the ampulla, and the left branch, the distal tip of the stent tip was placed in the common bile duct because the left IHD stent occlusion can be managed by US HGS, so that distal tip was placed the mid CBD. And lastly, right superior branch was stent deployment was done. So this patient's overall survival is 29 months and uncovered stent patency is 70.5 months. It is a much longer and better clinical response than usual case of a clutching tumor with liver mass. So let's summarize my talk. Malignant distal biliary obstruction can be a good therapeutic indication of EBRFA. Although EBRFA for malignant hilar biliary obstruction has a risk of complication, it is safe and feasible on the low RFA energy setting. You remember 2 technical points. First is because effective ablation length is estimated as 70% of RFA catheter length. So RFA electrode should be overlaid by like this tandem manner. Second technical point, additional biliary stenting should be placed due to post-RFA stricture. In conclusion, the diagnosis and treatment of malignant hilar biliary obstruction are challenging and complex. So in malignant hilar biliary obstruction, EBRFA is technically safe and feasible using 11 millimeter RFA catheter with low energy setting. However, its effectiveness in improving clinical outcome remains uncertain. We need more study. Thank you for your attention.
Thank you very much for your excellent talk. Let's open questions and comment.
Dr. Joe, very nice presentation. Any differences of the technical point for the ablation hilar cholangiocarcinoma comparing with the distal CVD obstruction?
Actually, is the common sequence is very similar to the distal and hilar bile duct, but hilar bile duct have a very complex biliovascular system, and especially right hepatic artery is very near the right hepatic duct. So we need to caution to perform the RFA in the right hepatic duct.
Same. So our institute is reducing exposing time for right hepatic duct ablation.
And in addition, the distal malignant biliary obstruction, pre-operative RFA may not interfere with subsequent surgery. However, high-level RFA may interfere with the surgical resection because they had many vascular stricture and adhesion interfere with the subsequent surgery. So in my institute, if the patient have a surgical candidate, we did not perform the EB-RFA for hilar lesion. Only the inoperable case, unresectable case, EB-RFA for hilar lesion was tried.
Any other questions? I have a question. Already you mentioned the efficacy of RFA for survival is controversial, but recently we can use immune checkpoint inhibitor. So is there a possibility drug therapy, before drug therapy, so additional RFA is be beneficial for patient survival?
I hope so, but we don't have enough data. But I think the combination treatment and local RFA therapy and systemic chemo or immunotherapy may be able to improve the patient's survival outcome. I expect, I hope.
Thank you.
Thank you. Yeah.
Let's move next speaker. Next speaker is Yoshihide Kano from Sendai Open Hospital. He is a rising star, and he conducted many clinical trials and published many articles in this field. So his topics is insight stent for hilar biliary obstruction. Please start.
Thank you for kind introduction. I'm Yoshihide Kano from Sendai City Medical Center. Thank you, Chairperson, Professor Fujisawa, Professor Kogure, and Professor Moon. It's my great honor to be here to talk here. I would like to talk about suprapapillary replacement, so-called inside plastic stents for unresectable biliary hilar obstructions. In the field of unresectable biliary hilar obstructions, uncovered metal stents and plastic stents have long been compared. And after several reports, including RCTs and meta-analysis shown in this slide, metal stents have become standard because of the advantage in longer stent patency period, as shown in this forest plot. Another meta-analysis involving retrospective studies has shown similar results, resulting in the ASGE's statement suggesting metal stent placement for patients who place high value on avoiding repeated interventions. However, uncovered metal stents have trade-off disadvantages, as you know, including costs, technical difficulty, tumor ingress, and removability. By the way, in previous, all of the 3 previous studies, uncovered metal stents were compared to plastic stents placed across the papilla. The compared outcomes of plastic stents above the papilla and metal stents above the papilla have been unknown. Several retrospective studies were conducted reporting feasibility and relatively long patency periods compared to traditional plastic stents. Then plastic stents, so-called inside plastic stents have become able to be easily deployed since some Japanese companies released several kinds of products with long threads for removal. Stents are preloaded on the delivery system and can be pushed similarly to other plastic stents. The lineup includes products with different length, different angles, and different caliber sizes. After the launch of such stents, Professor Kogure, along with Professor Isayama, has reported a multi-center prospective study on inside stents using the dedicated stents. The TRBO was reported to be 4.7 months. It's roughly equivalent to 140 days. And in addition, the latest RCT by Kurita et al. Has shown that inside plastic stents were superior to stent across the papilla in terms of the stent patency periods. Therefore, we are motivated and we planned and conducted multi-center RCT to compare inside plastic stents and metal stents. Eligible patients were those who with unresectable high biliary obstruction at bismuth level of 2 or more. This study was designed as seamless phase 2-3 study with sample size calculation for each phase. The size was defined to be 130 for phase 3 section and 60 for phase 2 section. The 12 Japanese high-volume centers were involved in this study. This is main inclusion and exclusion criteria. Main inclusion criteria were either malignant, unresectable obstructions with a total biliary 2 or more, and no previous history of biliary stenting. We dealt with just initial permanent stenting. Surgically altered anatomy and myriad segmentation of the biliary tree were excluded. This is flow diagram. Until the planned ending date, 87 patients were recruited and randomized. This study culminated in a phase 2 study at the planned ending date after careful discussion among representatives from involved institutions. Let me talk about the results. There are no differences in age, sex, and etiology, and preceding temporary drainage and biliary infection. Likewise, no differences were detected in blood examinations. And this is the result. Technical success was 100% for the inside plastic stent group and 96% for MS metal stent group. And there were no differences in ESD, EPBD performance, stent number, MS placement techniques. And this slide shows procedure-related adverse events. Overall, AE was seen in 10% for IPS group and 15% in MS group without statistical difference. No difference, but one cases of lethal pancreatitis in the MS group might necessitate attention. After eliminating technical failure cases, clinical success was analyzed. For both intention to treat and per protocol analysis, clinical success rate was around 94% in IPS group and 91% in MS group without statistical difference. And moreover, after eliminating clinical failure cases, TRBO or long-term outcomes were analyzed. The RBO occurred in 45% cases of IPS group and for 57% of MS group without a difference. And during the mean follow-up period shown here, the median TRBO was 250 days for the IPS group and 364 days for the MS group. There are no differences statistically. The Kaplan-Meier curves are relatively close. In summary, in our study, no statistical differences were observed in technical success rate, adverse events rate, clinical success rate, and time to RBO. This is our conclusions. Inside plastic stents can be an option for unresectable malignant hilar biliary obstruction, considering the similar outcomes of metal stents and their removability. With further development of the technical methodology or revision of the product design, the outcomes of inside plastic stents might be more improved. Thank you for your kind attention.
Thank you for a nice presentation. Now let's open a question and comments.
I'm Hamada from the University of Tokyo. Thank you for your nice talk, Yoshida.
Thank you.
I've got two questions on your presentation. One is, do you usually perform sphincterectomy when placing an inside stent or a metal stent above the ampulla? If yes, I wonder if the duodenal-biliary reflux is really prevented by inside stent. If no, I want to know how to prevent pancreatitis in your experience. And the second question is, given the super nice result of your randomized trial, do you recommend the inside stent placement during all the time alongside, until the patient death? I mean, the entire period of stent demanding time. After the occlusion of the initial inside stent, the biliary system might be full of debris. Then the prevention of duodenal biliary reflux might not be effective. Do you recommend?
First of all, thank you for your insightful questions. For the first question, in my opinion, EST should be performed in some cases that requires sphincterotomy, such as patients with small papilla or difficult papilla. And actually, in our RCT, EST was performed for around half of patients. In the protocol, EST was not prohibited, but not recommended. Finally, the half of patients underwent EST. And in my opinion, EST might be related to reflux of intestinal juice, but it's not. It may be not massive, not major problem, I think. So, in my opinion, EST should be performed in some cases.
Yeah, totally agree. Maybe the prevention of the massive, big mass of food debris might be effective on the prolongation of the stent patency, I think.
It can be.
In addition to the duodenal juice.
Yeah. Thank you. And for second question, inside plastic stents should be placed all the time To be honest, I don't have answer to your question, but in real clinical practice, we can't place inside plastic stents in some cases because of the difficulty to access the branch with acute curve or very tight stricture. And for such cases, across the papilla placement occasionally required. And even with inside plastic stents, There were cases, we encountered cases with very short stent patency period. For such cases, we metal stents or other interventions with or without combination of EUS guided route or percutaneous route are needed, I think.
Thank you so much. I ask because it might be very tricky to exchange this inside stent for me. Thank you so much.
Really? Thank you.
Dr. Kano, very nice presentation.
Thank you.
So 2 questions. Do you have any stent patency about inside the plastic stent comparing conventional plastic stent transpopularly located in your institute?
Thank you for your question. Actually, I don't have the data, but the previous data, in our previous data, the across the popular plastic stents had 99 days stent patency period.
Okay.
We have never compared directly, but 99 days and above the popular placement was related to more than 200 days stent patency. So.
Okay, because I'm fully understand like a middle stent have a larger diameter, but the plastic stent is very small diameter and long length. So I'm not sure the kind of duodenal-biliary reflux can be the real important factor for affecting of stent patency. And number 2 is actually your stent patency of inside the plastic stent from your study. Actually, it's extremely longer than comparing with other study result. What kind of secret of your institute?
I don't know the reason. To be honest, our data for inside plastic stents were more better than this study, but that was single center study. It's mysterious, so we must conduct a multi-center study. So, but I didn't make values, wrong values, so it's honest values. I don't know the reason for this good outcomes.
Okay, thank you. Very nice technique.
I'm Matsubara from Saitama Medical University. Thank you for your good presentation and good study. I have one question. I think the cause of RBO are different in plastic stent and metal stent. In plastic stent, bacterial biofilm or sludge is a major cause of obstruction. However, the metal stent is mainly obstructed by tumor ingrowth. So I have one question. Was there any differences in the number of cholangitis patients and or the prior inhibited placement in both groups, between both groups?
You mean how many patients had active infection?
Yes.
Before initial drainage?
Yeah. When permanent drainage.
Permanent drainage. First
active
permanent
infection.
drainage.
Yes.
Thank you for your insightful question. In our data, around 30% for both groups had infectious cholangitis at the timing of permanent drainage. No differences between groups.
Okay. Is there any difference of number of patients receiving nasal tube before prior?
No differences. Yeah.
Thank you. Thank you. Good
Thank you
insight.
for your question.
Thank you. Fruitful and hot discussion, Professor Khan. Thank you.
Thank you.
It's great honor to introduce the last speaker of our session, Dr. Takeshi Ogura. As you know, he is a great endoscopist for interventional EOS and with many, many publications. And our good friend, today he will talk about management of hilar obstruction with EOS.
Okay,
Takeshi,
thank you for
please.
kind introduction. First of all, it is my great honor to be here. So it is my pleasure. So my topic is management of hilar obstruction with EOS. So in case of unresectable mild hilar biliary obstruction, we should consider the various things as shown in this slide. So biliary stenting under ESP guidance is a gold standard technique to treat biliary obstruction, such as side-by-side or stent-in-stent techniques. So in case of unresectable MHB or multiple stent deployment is usually performed. However, these techniques, I think, have several concerns. So this patient was complicated with malignant hilar biliary obstruction. We deployed the uncovered metal stent using stent-in-stent techniques, but biliary obstruction was complicated. So we tried to intervention like this. So this patient underwent several interventions. So over 10 metal stent is deployed. So the difficulties may be increased by repeating the intervention in such cases. Also, according to keynote trial, median overall survival was over 1 year in pembrolizumab group compared with placebo groups. So due to recent improvement of systematic chemotherapy, we should pay attention to stent patency more carefully. Recently, US guided biliary drainage has been widely performed for patients with failed ERCP or inaccessible papilla, such as surgical alternative anatomy or duodenal obstruction. Stent patency might be favorable. Therefore, we do not deploy the stent across the tumor site. So, how about the recommendation of USBD for MHBO? According to ESGE guideline, USBD should be only considered for the left side was inadequately drained. Also, right hepatic bile duct drainage was not described. In addition, according to ASGE guideline, USBD for MHBO was not described. So in this guideline, only above sentence such as there is much interest in the role of US to drain the standard USP cannulation could not be achieved or listed. Therefore, USBD for MHBO is not still established yet. However, challenging mind opens a new window of biliary drainage. So this schema shows a constable access route for MHBO. So three access techniques of USBD are constable for MHB drainage. So these techniques are selected based on patient's conditions such as duodenal obstruction, surgical alternate anatomy, or normal anatomy. So in case of normal anatomy, US guided hepatic gastrostomy HGS for left side and US guided hepaticoduodenostomy HDS for right side can be considered. So these should be considered as salvage techniques after failed ERCP in this time. So first of all, I'd like to talk about the standard techniques of US HGS. So as you can see here, the HPD is punctured using 90 gauge needle and 2 5-inch guide were deployed. The bile duct and stomach wall is dilated using 4 mm balloon catheters. Finally, partially covered metal stent is deployed from the left hepatic bile duct to the stomach. So, as you know, bile leakage is one of adverse events of US HGS. So we usually dilate the fistula using a balloon catheters or tapered mechanical dilator. However, if the hepatic length is short, bile leakage easily occurs after tract dilation like this. Also, this is mechanical dilation. However, after tract dilation, bile leakage can be observed. So, as you know, bile leakage or peritonitis is usually treated by conservative treatment. However, as shown in this CT image, sometimes we should additional US guided drainage. So this adverse event maybe decrease the patient quality of life or prolong the systematic chemotherapy. So we should prevent this adverse event. So to prevent these adverse events, we usually select the puncture routes across the enough hepatic parenchyma. So according to our previous study, over 2.5 mm is needed to prevent this adverse event. Therefore, bile duct puncture at the relatively central side is needed to prevent bile leakage in standard US guided hepatic gastrostomy. However, compared with distal malignant biliary obstruction, drainage area should be sufficiently obtained in case of MHBO. So therefore, there are several careful points during USBD for patients with MHBO. So to obtain enough biliary drainage area, so the periphery of IHBD should be punctured like this. So after the bile duct puncture, we deploy the guide wire. And in this case, we deploy the plastic stent. So compared with normal anatomy, normal case, distance drainage area is short. So you usually use a loop techniques like this. So to obtain enough drainage area, bile duct branch obstruction should be prevented, even in B3 branch or B2. So we should select the partially covered metal stent or plastic stent. So US guided hepatic duodenostomy is usually drained for right hepatic bile duct from the duodenum, has been first reported in 2013 by Korean groups. So this technique opens a new window of US BD for MHBO. So I'd like to talk about technical tips for US HDS or in case of MHBO. So during US HDS, to puncture the periphery of the IHBD, echo endoscope shape is very important. So echo endoscope direction for left side, like in right image, may be favorable usually. So to adjust the echo endoscope shape, you should move the echo endoscope not only US guidance, but also fluoroscopic guidance like this to prevent duodenal perforation. So I'd like to show the video of the US HDS. After the duodenoscope insertion into the duodenum, we puncture the right hepatic bile duct using a color Doppler image to prevent vascular injuries. So after successful bile duct puncture, we inject the contrast medium. So after the two 5-inch guide wire deployed, so we dilate the fistula using ES dilator like this. So compared with left hepatic lobe, in right lobe is a very high volume. So we should prevent bile duct branch obstruction. So we chose the partially covered metal stent, like this is a partial size. So we can prevent bile duct obstruction, bile duct branch obstruction. So after this stent delivery system insertion, we deploy the stent using intrascope channel-less techniques. However, in case of the intervention, sometimes severe cholangitis is complicated. So rarely we do the right and left post drainage is needed. So in case of stimulate USBD, firstly, you should puncture, try to the USHDS firstly, because if the USHDS is firstly performed, duodenoscope, echo endoscope insertion into the duodenum, HDS stent is dislocated. So we should firstly perform the USHDS. So after the USHDS, we put the echo endoscope into the stomach, and the IHBD left bile duct is punctured, and the guide wire deployed, and the USHDS is performed. So recently, compared with comparison study between PT-BD and US-BD for right hepatic bile duct has been reported. So according to this retrospective study, US HDS shows the comparative safety to PT-BD for drainage for right HBD. However, HDS shows the longer stent patency and the lower frequency of intervention in patients with unresectable MHBO. So also, comparison study between ERCP and USBD as intervention has been reported. So according to this also retrospective study, stent patency after intervention was significantly higher in USBD group compared with ERCP. So in addition, intervention techniques is only potential factor associated with time to recurrent biliary obstruction. Also, in case of high-grade biliary obstruction, we previously comparison stent patency, but similar efficacy. Therefore, other intervention techniques, USBD can be considered as first-line rescue techniques. However, primary drainage for MHBO is not still reported. Therefore, RCT as a primary drainage of US HDS combined with HDS compared with ERCP is needed for MHBO. Finally, I'd like to talk about breaching techniques in case of surgical alternate anatomy. So we previously reported these techniques in 2015. Firstly, we deployed the uncovered metal stent from the left hepatic bile duct to right to the left hepatic bile duct. Finally, stent placement is performed from the stomach. So usually, sometimes the angle between right HBD and left HBD is acute or like this. In such cases, controllable ERCP catheters or sphincterotomy is sometimes useful. I'd like to the video. So this patient underwent a duodenal stenting, so we tried to USBD. So as you can see here, the higher obstruction can be observed. So we tried to insert the guide wire in the right side, fortunately successfully deployed. So to insert the stent delivery system, usually we dilate the higher side using a 4 mm balloon catheters. And then we firstly deploy the left hepatic bile duct to the left side. So I would like to recommend to use a laser cut type metal stent to prevent misplacement or due to stent shortening. So finally, partially covered metal stent deployment. So in my conclusion, USBD for MHBO is feasible and safe. So also, in case of high-grade stricture, HDS with HDS or breaching techniques may be indicated. However, anterior bile duct cannot be usually drained, so it is a careful point. So because of lacking enough evidence, further study is needed. In addition, further devices improvement is needed. So thank you for your kind attention.
Very nice presentation, Dr. Ogura. Now it's open for discussion and questions and from audience. How about combination drainage, ERCP and EUS?
Yes. Oh, now I try to conduct the prospective trial. So right side is fully covered metal stent, and the left side is HDS. So we now conduct a pilot study. So in the future, I report it. So, but in my opinion, stent patency is very well. So because right side is fully covered, and the left side is HGS.
So adverse event from your now ongoing study?
No, I registered 25 cases, but one patient was complicated with acute cholecystitis due to stent deployment. So this patient underwent USGBD. Severe adverse events were not seen in this time.
So for hepatoduodenostomy, so could you recommend the kind of procedure to average skilled doctor also, and even just a rescue for highly experienced
I think
doctor?
if right HBD is enoughly dilated, procedure itself is safe compared with HGS because stent migration cannot be difficulty occurs because, as you know, stomach is a very movement, but the duodenum is very close to the hepatic hepatic parenchyma. Therefore, US HGS is not so difficult compared with HGS. So, endoscopists who trained US FNA and US GBT, HGS can be safety performed, I think.
Very nice. Any questions, comment? You showed very nice videos and techniques. So do you manipulate guide wire yourself or ask the assistant?
To train the trainee, firstly, my assistant is manipulates the guide wire. But the resistance between the needle and the guide wire is difficulty felt by the assistant. So usually I using the physician control guide wire techniques.
Thank you. Any questions, comment? Okay, and we would like close our thank you, Dr. Ogura. It was a very nice, interesting session. So thank you for all speakers and audience as a last session. Have a good evening. Thank you.
Thank you very much, the moderators and lecturers. Now we will close all program of room 12. Thank you very much for your participation today.
All speakers, could you come front?